Hi, I'm Dr. Ann Kellams. I'm a professor of pediatrics and director of the UVA Breastfeeding Medicine program at the University of Virginia School of Medicine in Charlottesville, Virginia, in the USA. I'm going to talk for a few minutes about what to do if supplementation has occurred and how to preserve breastfeeding. So, supplementation does not have to go on indefinitely in most cases, and we want to make sure that we're doing it in a way that makes it easier for families to get back to their goal of breastfeeding. So the first thing that comes to mind is what to supplement with. If you find, and we have a great protocol about this, the ABM Clinical Protocol number 3 about supplementation, if you find that there's a medical need for supplementation, or there was not a medical need, but the family was worried or for some reason wanted to introduce formula, the first thing I would try to propose or talk about with them would be, let's see if we can maximize signaling for you, and let's see if there's some milk in there that perhaps baby hasn't been effectively getting out yet, that we could have you hand express or pump or help the baby attach differently such that the extra milk they get is your own fresh milk. If that is not possible, or let's say there isn't any milk yet, or the family continues to be worried, then our first choice of supplementation would be pasteurized donor milk. And many newborn services across the U.S. at least are starting to use pasteurized donor milk, even in the term newborn population. There was some time when some would recommend protein hydrolysate formula, and I would say the evidence is mixed as to whether or not that actually makes a difference for the later development of food allergy. And so it may or may not be something useful. And then the last choice would be standard infant formula. If supplementation is used, here are some strategies to try to preserve breastfeeding. One would be to think about, okay, well, why did we get here in the first place, and what can we do about that? Was it because of pain? Was it because maybe mom has a risk factor for delay in lactogenesis too? Like, let's make sure that we understand how we got there to begin with. And then for every baby in this situation, encouraging skin-to-skin time. This gives mom's body a hormonal boost, and it also has been shown that babies who are skin-to-skin will cue to feed more often, and then they're right there with mom, and that's a great time to practice or to do some more signaling. So keeping the baby skin-to-skin with the breastfeeding parent while that parent is awake and able to monitor them. Rooming in. This would not be a great baby to send off to a newborn nursery down the hall. You want them to be together so that there's no chance that if the baby's awake and stirring and cueing to feed, that they don't feed. That's an attempt to increase frequency. Hand expression or pumping for each time the baby gets anything other than mother's fresh milk. So if you don't do that, and baby goes to the breast, but then they're still hungry and they get formula, for example, mom's body is over here thinking, baby's not hungry anymore. We're making the perfect amount. We don't need to increase production. And that's the exact opposite of what we want to be telling the body, right? So if baby's getting a bottle over here, we want you to be hand expressing or pumping, even if nothing comes out, because you're mimicking that hungry baby staying at the breast. Then the body goes, oh my gosh, we're empty, but the baby is still signaling we need to make more milk. And that's a very strong signal to produce more milk. This is a baby that you would want to have lactation and breastfeeding medicine professionals involved with, evaluating baby, evaluating mom, observing feedings to make sure that any time spent feeding is effective time and helping them get to their goal. And then have a clear endpoint. Like I will often say, if there's any supplementation going on in the first day or so, this is just going to be until your body kicks in and starts producing more. And we're going to do everything we can to make sure that happens. And so as you're making more, we're going to use less and less of this supplementation so that, every now and then you have somebody come back and they're 2 months old or 4 months old and started supplementing at day 2, and they're still adding formula every single time, but they're making 24 ounces of milk. So be sure to put an endpoint. limiting the amount of supplement to the physiologic need of the baby on that day, and it does change by the day early on. And the ABM clinical protocol number 3 on supplementation is a great resource for that. And then considering an alternate feeding method. Not every baby will freely and by choice go back and forth with different feeding methods from the get-go. And so if there's a chance to avoid an artificial nipple and to supplement at the breast or in a way that they have to root and then open wide and then do some suckling and then get milk, we would prefer that, because you don't know you have a baby with a problem until you have a problem. And then make sure to teach them safe formula preparation. And I think that's something that is a gap in our care of newborns, especially in the United States, is that I don't think a lot of families realize that, for example, the powdered formula is not sterile. And we've had incidences of contamination with bacteria.